Dear colleagues, dear friends, a very warm welcome to this last main arena sessions of today, an Abbott-sponsored session, where we would like to discuss with you state-of-the-art therapy of mitral regurgitation. My name is Philipp Lurz from Mainz, and I have the pleasure to guide you through that session together with Professor Michael Borger, Director of Cardiac Surgery in Leipzig, and Chair of the brand new Heart Valve Guidelines, which we will discuss very much also during that session. What we would like to achieve today is, as said, create together with you and our excellent panel a session on state-of-the-art therapy of mitral regurgitation. And when we talk about state-of-the-art, let's go to the objectives. We mean that state-of-the-art obviously means that all our decisions and discussions should be based on evidence and on the latest guidelines. Secondly, state-of-the-art also means that we not only use the phrase of the heart team, but we really try to live up to the idea of the heart team. And we do have a panel which consists obviously of interventional cardiology, we have cardiac surgery, we have also EP specialists, and we have specialists in heart failure therapies. And then lastly, state-of-the-art also means that we will talk and see during a fantastic live case from Vigo, the latest iteration, the G5 MitraClip system. As said, this is our fantastic panel and all the people who are involved, so a tremendous expertise. But most importantly, we want you to participate, and with that, I hand over to Michael.
Thanks very much, Philip. So yeah, as you can see on the screen here, you have the ability to ask questions through the mobile app, and these will appear here on the stage, and then we'll distribute them amongst the appropriate speakers. Or you can, of course, come to the microphones and pose your questions during the entire session. It is a very tight session. We actually have three different disease etiologies that we'll be addressing. The first one being ventricular secondary MR, the second one being atrial secondary MR, and the third one being primary mitral regurgitation. And with no further ado, I'll ask Marek Grije from Poznań, Poland, to give the first case presentation of a patient with ventricular secondary MR.
Thank you very much. Thank you very much, Philip, Michael. So my task for today is just to show you and start that session with a case presentation. Here are my conflicts. So I'd like to present a patient, 71 years old patient with dilated cardiomyopathy with low ejection fraction. However, that low ejection fraction was diagnosed, and that dilated cardiomyopathy was diagnosed more than 15 years ago. However, the patient was doing quite fine, except that within the last previous months, there was significant worsening of patient symptoms from concomitant diseases, hypertension, diabetes, and that patient is after VVI ICD implantation, which was done a few years ago. However, QRS complexes in that patient are quite narrow. That patient has also paroxysmal atrial fibrillation. When you look at echo examination, definitely there is an enlarged left ventricle, enlarged left atrium with significant severe mitral regurgitation with hypokinesia of all walls of the ventricle with the ejection fraction of 20%. His labs are showed significantly enlarged NT-proBNP with slightly decreased EGFR and slight anemia. Chest X-ray looks like that, and initial medication in that patient are like that. So with these medications, we decided, when we see that patient with worsening of patient symptoms, we decided that probably that patient is not treated according to the guidelines, and there is a time to change medications according to guidelines and reassess that patient within 3 months. So during that hospitalization, on hospital discharge, we discharged that patient on these guideline-directed medical therapy. So it was bisoprolol, small dose at the beginning, but with the aim to increase the dosage with Entresto, with the aim to increase it also with Flozin and diuretics. And The patient was readmitted to the hospital after 3 months, and it was admitted to the outpatient clinic. There was some minimal symptoms improvement. However, that patient was not able to tolerate higher dosage of beta blockers and sacubitril valsartan due to the low blood pressure and dizziness. And in fact, these dosages were definitely not, let's say, targeted doses of these drugs. And moreover, there were 3 episodes of paroxysmal atrial fibrillation since last visit. Echo examination performed at that time, I show you only in the TEE, and then TEE showed definitely enlarged left ventricle with significant mitral regurgitation, with a significant gap between, maybe not so huge, between anterior and posterior leaflet. And the TEE images on looks also like that. And now I need your help and your decision. What we should do with that patient? Should we optimize?
With you, Nicole, and your take on that, please.
Okay, so obviously I'm happy to see the results of the poll, the primary results of the poll, because I totally agree with what people are suggesting. So we have been for years considering that edge-to-edge or TMVR or whatever should be the end phase of the treatment we might offer to the patients with SMR and heart failure. But in reality, we know that it's very difficult, and we see the example here. It's very difficult to get to the point where the patient has really the optimal medical treatment. And this has a cost. If you look at the introduction of medical treatment in those patients with SMR, it comes with dizziness, hypotension, acute renal failure that reverses, and then you try again. And so somewhere, treating the SMR will simplify the optimization of medical treatment. So it's not supposed to be the end stage of the treatment. It's somewhere in the middle. And I just had a slide I wanted to show, which is a paper that was accepted today, actually, in ASC heart failure, where we are trying to suggest that actually it's supposed to be somewhere in between. So it's not like we treated, it's done, we hand over to the interventional, and end of discussion. Actually, MR correction should probably be in the middle between a first step of treatment optimization and very quickly introducing the MR correction, and then reverting back to still improving TEER, to still improving optimal medical treatment. I guess this patient obviously qualifies for this, an TEER reduction treatment at this point, and then optimization of medical treatment.
Very good. Now let's hear the heart failure perspective. We have Frederick Verbrugge with us.
So I might be slightly disadvantaged by the public if I see the poll. But of course, we should not forget that we treat an underlying disease, and the disease here, it is clearly heart failure. So we should try to optimize really everything, and the efforts by which we do it make some difference. I think, first of all, we need to consider all the foundational therapies and not just uptitrate them like all at once. In some patients that goes, in some patients it's a little bit more careful. What I'm missing in this case is clearly the hemodynamic assessment. If you're going to uptitrate a beta blocker in a patient who is in low output, they will not tolerate, they will become hypotensive. But if we optimize this first, maybe we get some Entresto aboard. Maybe we get to an opportunity where we can uptitrate the beta blocker and we make a difference. I think the 4 things, the 4 pillars here, they were tried. It's not so clear how they were tried, so maybe there was a way to go more slowly. Also, this patient clearly on the echo seems to have some congestion as well. So I would like to see numbers from a right heart cath. What I tend to do a lot of is if I do a right heart cath in such patient, I will bring down the wedge at rest to lower than 15. This is, even in advanced heart failure, this is very often possible at rest. And if this is not possible, I think we should also consider possibilities for end-stage heart failure treatments like transplant and LVAD. If we see that with optimizing the hemodynamics, the MR goes away, then maybe we should also consider things like pulmonary artery pressure monitoring and keeping the hemodynamics in track. And very often in these kind of patients with dilated cardiomyopathy, when you do it like that, you see that at a certain moment in time, the MR starts to progress again. And then, of course, you should go for the mitral intervention. but at the right moment in time. And this can even gain you some time before a transplant is needed.
One last question about timing. How long can we wait and potentially fail to increase GDMT, to optimize GDMT before we put patients at risk?
So I think in cases like these, you cannot wait too long. You actually want to be before you also kill the atria with the MR. So I think that here in such a severe case, I would go for a right heart cath, maybe admit the patient, quickly see what is possible. If you don't get this patient on better treatments, then you can proceed with intervention.
Maybe just one quick question already coming up then, Nicole. We know the results of MITRA-FR and COAPT. Where would you see this patient? I know we don't have all of the information here, but where do you think this patient would fit in?
Yeah, as you said, we don't have all the information to give a correct answer, but I guess we should maybe start to get away from MITRA, is it a MITRA-FR and a COAPT, and try to deal with the patients. And we've seen other studies now. We don't need to be stuck with those two, and try to look at what the patient is having. This patient, for me, is not in chronic AF yet, but he's getting more and more episodes. So he's getting ready to get to chronic AFib, and he will lose his atrial contraction. He's going to get bad. He's suffering, he's dizzy, he's hypertensive. So I guess we have to offer something. Obviously, the LV is not completely dead from what we've seen, but we don't have all the info. Maybe we'll have more images later, and we'll be able to judge.
Fantastic. So let's see what you have done with that patient.
So with that patient, we decided, I'm not sure yet, you can see it. So after the discussion with the heart team, our decision was to go ahead at that time, not wait to the up titration of the drugs, but go ahead with the mitral clip. So it was one of our first cases done with G5 generation of the mitral clip from Abbott. So at the beginning, we thought that since the left ventricle function was quite poor, that maybe it would be possible to go ahead just with one clip. However, with one clip, as you can see here, definitely the result was not optimal. We tried to readjust that clip, move it a little bit to more central, and just to change our orientation a little bit. However, still, even with several attempts of grasping, we were not able to obtain the perfect result. And here you can see on your left picture, looking at the screen, that we obtained quite good results from the medial aspect. However, there is still a significant change jet on the lateral side. So we decided that there is a time to add the second clip, and second, at that time, XT clip, which was added on the lateral side of that patient. And you can see that the final result looks like that we were able completely diminished mitral regurgitation. Through that valve was low, mean gradient it's only 2. That patient was discharged home 2 days after procedure, and at this time, what was discussed here, we were now able to up-titrate the drugs for heart failure, and at that time, these drugs were well tolerated. Moreover, there was a significant clinical improvement in that patient, and follow-up transthoracic echo was done in October, showing slight increase in the ejection fraction with just mild mitral regurgitation. Thank you.
Very good. I think we can all agree this is procedurally a fantastic result. Michael, what has been done here, is this according to guidelines?
Yes. The guidelines have been significantly changed from the 2021 version, now with a class 1 recommendation for these types of patients based on 3 trials and a meta-analysis to prevent heart failure and improve symptoms. And you saw hopefully a very good echocardiographic result, and hopefully also a good clinical result. One thing that we did also address in the guidelines, Nina, as you know, was it's in the text, it's not in the recommendations themselves, but we did say that up-titrating medical treatment is oftentimes possible after transcatheter therapy, do you have a comment on that here?
Yeah, absolutely. I think that was a crucial point demonstrated by the case, and tells you how much you have to, like their fellow colleagues does, follow the patient in all the journey, because this patient was stable for years and then in once had a completely change of the symptoms, and titration of the therapy was possible, but in a certain limit, and this really helped for the further up titration later on, which helps now the ventricle, which is the primary problem, of course. So I think it's very crucial, but indeed the criteria that were suggested, like the very large ventricle or probably the less severe MR, were part of the other trials, but now we're learning how to treat them then more properly.
Excellent. Thanks very much, Mark. A great case. So we will now move on to the second presentation or second section of this very busy schedule, where we'll be talking about atrial secondary MR, which was a newly defined etiology within the guidelines. We felt very strongly that this should be very clearly defined because they have a very different trajectory of their prognosis, these patients, and we hope that our definition will be standard definition from this point going forward. So our next speaker will be Moni Shuvi, talking about a patient with persistent atrial secondary MR.
Hi, thank you very much for the invitation. I hope that the definition will be fine. I'm not sure about it because I'm not sure that everyone knows what is the proper definition for atrial MR. I'm Moni Shuvi, I'm from Israel, Jerusalem, and this is my conflict of interest. I present a 72-year-old woman that presents with dyspnea, fatigue, weakness, and significant functional decline over the last 4 months. She was diagnosed with congestive heart failure. Her medical history includes of a classic metabolic syndrome. She had chronic kidney disease of creatinine 1.5, diabetes with diabetic nephropathy, hypertension, hyperlipidemia. She has severe obesity. Her BMI is 56, and she has severe obstructive sleep apnea and requires CPAP at nights. Cardiac evaluation shows normal coronary arteries and also normal MRI for a question of cardiomyopathy. And she also has persistent atrial fibrillation, known for at least a few years. She underwent several unsuccessful cardioversion and AFib ablation, but still she is in atrial fibrillation going in and out to sinus rhythm. This is her echocardiogram. We can see here mildly reduced LV dysfunction, ejection fraction around 35. We can see dilatation of both atria, and we can see here severe mitral regurgitation going back to the pulmonic vein. Next, we see similar pictures showing the right heart, showing also she has significant tricuspid regurgitation. And if we can conclude, she has severe mitral regurgitation, severely enlarged LA, severe pulmonary hypertension with TI greater than 50, EF of 40. This is a TEE evaluation. We can see mildly thickened leaflets, but with good length. And we can see the jet of the MR, mildly eccentric, but mostly central. We can see the 3D picture, significant and severe mitral regurgitation. So what should be the next step with this patient? Should we try again to do an AFib ablation or other magics of the electrophysiologist? Maybe try and fix the mitral first and then consider treatment for her atrial fibrillation, or although she has severe comorbidities, send her for surgery and surgical AF ablation.
So thanks very much, Moni. Now we find out if people actually read the guidelines. Nico, this is sort of a mixed patient, right? It's not just atrial secondary MR, but also ventricular secondary MR. And we know that if you wait too long with atrial secondary MR, those patients will start to transition. There is a spectrum there. And therefore, in the guidelines, we tried to state, please intervene or think about intervention at least earlier in the disease process before it gets to this stage. Do you have a way to sort of try to help us in that respect?
Yeah, I was thinking whether or not there was a, that jet wasn't completely central, and so there must have been some restriction on that posterior leaflet. When you start thinking about atrial FMR and you start to get a more eccentric jet, sometimes you start thinking whether or not there's an atriogenic component to this. Sometimes when you get severe left atrial dilatation, that posterior dilatation can lead to posterior leaflet pulling and cause still it's atrial FMR, but give you a jet that's more eccentric, and we call that atriogenic FMR. But in this case, we see that the LV is not completely normal, so it's definitely a combined picture. But just to finish off, those patients with atriogenic MR tend to have worse procedural outcomes, technical success, than those with just pure atrial FMR.
It's interesting to see that the vast majority would go for treatment of that pathology. I'm not saying that I disagree, but we should remind ourselves that in the guidelines we have a 2B indication for this scenario, so it needs a little bit more of a thorough discussion. And we will do that, and starting with Federico De Marco, who will give us his take on things here.
We have a couple of slides just to nail down a couple of concepts about atriogenic FMR. First of all, as stated, the guidelines have introduced in 2025 the concept of atriogenic with a different degree of recommendation for TEER and surgery. Next slide. And it's interesting to see in what sense the patients with atriogenic FMR are different from ventricular FMR. They tend to be a little bit elderly. They have an equally bad quality of life with a low KCCQ score. And the left atrium is more dilated, and strangely enough, sometimes the AP diameter can even be smaller as compared to the ventricular counterparts. Next. We know that TEER works well in these patients with a very satisfactory results in terms both of MR reduction and symptom improvement. And the symptoms and MR are maintained low also at 1 year. And the very next slide will show us exactly what Nico was referring to. There are different subsets of the atriogenic FMR. When you have this posterior displacement of the posterior annulus, you can have this hamstringing, which makes it for a difficult, technical. It makes it difficult to have a good result in this subset of patients. So the patient that we just seen might belong to this patient subgroup.
Very good, but let's also hear the EP's perspective of things, please, Prabha.
Thank you. Thank you. If you just put my slide up. So we know that maintaining sinus rhythm will improve chamber function in all 4 chambers. So in this study where they followed up patients who were maintained in sinus rhythm versus those who remained in AF, we see that both the mitral regurgitation and tricuspid regurgitation improves, as well as overall chamber function in all 4 chambers. If you just go to the next slide. So when we look at ablation, one of the things we've got to take into account is obviously the MR is working against us. So if we can maintain sinus rhythm, then we start getting good outcomes. So in the Cabana trial, which is one of our biggest randomized controlled trials, looking at sinus AF ablation versus medical therapy, if you have MR to start with, then your overall symptom benefit with ablation is better, but your AF recurrence rate is also higher. So that's slightly counterintuitive, but essentially what we're saying is if you manage to maintain sinus rhythm in these patients, they do very well. So if you go to the next slide, so if you look at MR evolution, just having the AF ablation will push you towards having improved mitral regurgitation over the 1 year period, but taking into account there will be a high failure rate as well in terms of trying to maintain sinus rhythm. So in the case that we're discussed, yes, they've had 1 failed ablation, but we know that at least 30 to 40% of patients will need a second ablation. So trying to aggressively maintain sinus rhythm is still worth considering.
Very good. I think here we have to go back to the guidelines and to the guideline chair, Michael, for a second, to briefly discuss first the role of rhythm control in these patients, and then secondly also maybe explain a little bit the decision about the preference choice surgery as opposed to TEER.
Yeah, so the task force felt that there wasn't really enough data yet for supporting the stance that converting to sinus rhythm. We know that results in reverse remodeling of the atrium, but there's not really a lot of data showing that markedly reduces the FMR or the atrial FMR, but we need more data. Then you do see that there's a 2A recommendation for surgery and a 2B for transcatheter therapy or for TEER. And the surgical literature is there's quite a large number of studies with also quite a long length of follow-up, 5 to 7 years. And there is the REVEAL AFMR registry from Japan, over 1,000 patients, of which 117 underwent surgery. And the surgical patients actually had a survival advantage even though they were sicker than the medically managed patients. And the advantage was quite big, was even bigger when they matched. And with surgery, you can address the dilated mitral annulus. Oftentimes, the tricuspid annulus is also dilated. About 80% of patients in that Japanese registry also underwent tricuspid valve repair. Plus, you can do an ablation. Plus, you can close the left atrial appendage. Whereas for TEER, the amount of data was not quite as substantial, and it wasn't nearly as long as surgery. We're talking about 18 months. The recent Japanese comparison of OCEAN and Atrial and the two registries from Japan showed that, yeah, there was benefit for TEER compared to medical therapy, not quite as big as surgery. And also, if there's moderate MR, which occurs in 20% of patients, or if there's gradient more than 5, which also is not infrequent, that those patients don't profit quite as much. And that's why we put surgery a little bit ahead of TEER.
Very good. But it's also true that many of these patients are at advanced age. They are sometimes at high surgical risk, so TEER plays already a role in these patients. But let's see what you have done, Moni.
Okay, so you can see here that we decided to go for TEER procedure. You can see again here the TE showing severe central MR, a bit eccentric as it was shown before. And we can see here that the first NTW goes in with a very nice grasp. We see some smoke in the atrium, suggesting a decrease in the MR. And then we can see here that there is still area in medial to the first one. And we can see there is a jet from there. So we added another clip medial to the first one. It wasn't really a problem because when you have a huge atrium, you can easily add another one more medially. And this is the last tissue bridge with very mild medial MR. So 2 NTWs were inserted, mild residual MR, and then we did what we always do in patients with atrial fibrillation. We cardiovert them in the end of the procedure because they are sedated, and we got her into sinus rhythm. And then she had an AFib ablation a few months later in order to make it more solid. And the patient was discharged without complication and is in sinus rhythm ever since. And this is her echo a few months later. And you can see even that there is some improvement in the LV, because sometimes so-called ventricular MR is atrial MR, that atrial fibrillation causes a decrease in the LV. And after you treat the atrial fibrillation, the LV improves. So this is her current ejection fraction, about 45 to 50. Mild MR, the pulmonary hypertension went down, and she's feeling very good. So if I might say, sometimes the atrial myopathy is a disease that includes atrial fibrillation and functional MR. And sometimes you need to treat the MR in order to facilitate better therapy for the atrial fibrillation.
Philip, we do have a couple of questions on the same topic. She was an obese patient. Should she be on GLP-1 antagonist nowadays or SGLT2 therapy?
Frederick?
Definitely, I think. So in any patient with atrial myopathy, I would treat with an SGLT2 inhibitor and an MRA. Both drugs have shown that they reduce the risk of AFib. There are some emerging data about atrial remodeling. I think with such a high BMI, a GLP agonist would definitely benefit her as well.
That looks like an excellent outcome, especially that the ventricular function there was reverse remodeling that occurred as well, which honestly I wasn't expecting.
So it was very interesting because when she was in sinus rhythm during those years, her LV became better, which suggested that the LV decrease is due to the atrial fibrillation, which is not very rare to see, that after you treat the atrial fibrillation, the LV improves.
Prapa, do you want to change your answer now? Do you say this was the right next choice and then ablation, or do you think a second ablation would have been a better choice first?
No, I think that absolutely you've had a great outcome, right? So there's no question about that. I think looking at her data from beforehand, the likelihood of success of maintaining sinus rhythm long term was going to be limited. And the number of patients we do AF ablations on in severe MR is still quite limited. So the moderate to severe MR patients do very well with ablation. The severe MR patients we don't take to the lab as much, which is why the data doesn't exist.
One last question, is the TR improved on this patient?
I think that it went into moderate. When the pulmonary pressure went down, the TR improved to moderate, but I don't have the picture, so I'm not convinced that I can show.
Sorry, one more question for you, Philip. Why not use XTW?
I wanted to pass that on to Nico because there's always a discussion about NTW, XTW in these patients where you have almost a negative coaptation length. What would you have done?
Well, I don't know what the leaflet length was of the posterior leaflet.
It was good enough, but we try not to put XTWs on functional MR in general.
Yeah, I think I would have started with an XTW.
Okay.
Yeah.
I think, there's still a lot of controversy in that pathology, whether it should be the longer or the shorter clips. But whenever you have an outcome as you have shown, then it's perfect. It doesn't matter what you have chosen because the outcome is perfect. And it proves that we can treat these atrial pathologies very effectively by transcatheter means using the mitral clip. Okay, thank you very much.
Thank you.
And then we move on to the third part, which most importantly entails a live case.
Correct. So a live case from Vigo, Spain, and I'm given the pleasure of introducing this case on behalf of Drs. Lorero and his team of experts. So this is a patient who will be receiving the MitraClip G5 system. This is a 65-year-old woman who was referred for NYHA2, shortness of breath. She had a history of paroxysmal atrial fibrillation and was admitted at least once before in January with heart failure. Very importantly, she had advanced Parkinson disease and is actually waiting for a neurosurgical procedure in order to treat her Parkinson's. She also has a history of hypothyroidism. The cardiovascular risk factors are the usual: hypertension, former smoker. As I said, NYHA2 symptoms. She's not obese. And she has significant motor limitations, and maybe the team from Vigo can expound on that a little bit once we start the case. So this is the patient's medical management, and I think we could all agree that the medical management was substantial, and despite this fact, she was still symptomatic. These are her blood work. The BNP is mild, moderately elevated. Kidney function is intact, as is hepatic function. This is her EKG, currently showing sinus rhythm with a narrow QRS. And here is the echo, which of course we'll be showing shortly in even more detail, but a preserved ejection fraction with bileaflet prolapse, so a typical Barlow's type of valve, and normal RV function, but still mild to moderate tricuspid regurgitation. The EROA for Nina was 0.34, and as I said, mild to moderate TR. On CT, the mitral annulus was markedly dilated, which we expect for patients with Barlow's disease with a perimeter of 153 millimeters. And as a summary then, 65-year-old woman with severe primary MR due to Barlow's disease and a preserved EF, and also a limiting neurologic disorder, that is Parkinson's, awaiting neurosurgery. So we will go to Vigo and...
We do the poll first.
I'm sorry?
Now let's have another poll. But the options should be still part of that slide deck, shouldn't it? So So maybe in between, maybe I need to ask you, would you consider that patient to be at high risk for surgery?
That's why I said I'm interested to hear what the physical limitations are. 65-year-old with normal EF, I definitely would not consider high risk for surgery, but it really depends on her neurologic status.
But obviously it requires a bit of a discussion whether intervention or surgery is the preferred choice of therapy here.
And that's what we will be discussing in just a moment, but we're still waiting for the poll. Unfortunately, I can't find the poll here, the poll question.
Then we go right into the discussion.
There it
The poll
is.
is ongoing.
Ah, there it is. Very good. Thank you very much, Nicole. Thank you for helping us out here. Okay, so let's see what the majority thinks, whether it should be surgery, whether it should be TEER, or whether it should be TMVR, if feasible in that scenario. So it seems that there is still a majority favoring surgery. Federico, what's your take on that?
Well, I think what Mike just said is really appropriate. We do not know what's the real status of her neurologic disease, so I think that's the first question we need to do to Roy once we connect with Vigo. But this looks like a patient which also can have a good outcome in terms of MR reduction with a transcatheter repair. The anatomy doesn't look super complex despite being a Barlow disease. So
you had a couple of slides here. Maybe we can just show the slides now for Federico?
Yeah.
Okay.
The slides were, again, to reinforce the fact that there has been an upgrade in the guidelines for TEER in primary mitral regurgitation, which went up to level 2A with level of evidence B. Next slide, and this is based on some data. We have the expand G4 data in showing that in primary mitral regurgitation we can have 88.8% of patients having at 1 year at most a mild residual degree of mitral regurgitation. Next slide, and this holds true also in complex anatomy with some degrees of complexity. Next slide. And this slide is actually new because earlier today we have seen also the 2-year data of the expand G4 showing that we have a good increase in quality of life for primary mitral regurgitation patients. Next slide, also the New York Heart Association class is maintained also at the 2-year time frames. So at least at short term, this patient can have a good outcome.
Then I will proceed with my arguments then about surgery. And I only have 3 quick slides. Maybe if we can show them here. Yeah, so I was asked to say that this patient should undergo surgery. These are my conflicts of interest. So in the 2025 guidelines, we have, like in the 2021 version, surgery as the treatment of choice for patients with primary MR if they have symptoms or if they're asymptomatic with marked LV dysfunction. But we also have a new 1B recommendation for asymptomatic patients if they have 3 of those 4 criteria: atrial fibrillation, pulmonary hypertension, left atrial dilatation, or concomitant secondary TEER. In addition, there's a new recommendation for minimal invasive surgery based on a large randomized trial that was recently published. And if we look at the results for surgery, this is from the Milan San Rafael group. First of all, the survival at 10 years was 90%. And then the freedom from reoperation on the mitral valve was fantastic at almost 97% at 10 years. And the freedom from rehospitalization also fantastic at 92% at 10 years. In addition, this paper is in press, but it's from Cleveland Clinic. It is a small number of patients undergoing TEER for primary MR that are propensity matched to a small number of patients undergoing surgery for primary MR, with all the caveats that belong to a retrospective study. But certainly this shows that at least with regards to recurrent, moderate, or more MR, surgery gives better results. So I would say if we are going to operate on somebody with a degenerative neurologic disease, which is not that rapidly progressive Parkinson's, that we know that, it's better to probably get it done right the first time and rather than trying to redo it again a few years down the road. And that's why I think surgery is the right option.
Very good. So with all these thoughts and obviously considerations about the guidelines, we now move over finally to Vigo, to Roy Esteves and his team, to hear what they have decided, what their plan will be, and obviously to see how they treat that lady. So can we move over to Vigo, please?
Good evening from our Cunqueiro Hospital in Vigo, where we do this special case. We are with the nurses of our team in the cath labs, also with the anesthesiologist, Dr. Vázquez, and the first operator will be Rodrigo Esteves, that will tell you about the strategy to treat this case. And after that, Dr. Barreiro in the echo will show us the imaging that takes during the stay of the patient in the cath lab.
So good evening, guys, from Vigo. So operator strategy, as we already have done in the prior case, we do echo-guided venous puncture, transeptal crossing with the versa cross to be precise in the position of the puncture. In this case, specifically important because we have not so large atrium and the height is paramount to do a nice procedure. We will show how we use the latest iteration of the Mitral Clip G5, and we explain a little bit some of the new features. And then we will try to implant 2 long and wide clips, probably because this is a lot of redundant tissue there. We need to do a good grasp, decrease the annular diameter as well. And we will close the access with a ProGlide plus probably a figure of 8 stitch. And now Dr. Barreiro is going to explain briefly the case and where we are now.
Roy, before we do that, just one comment, because we did a poll and the majority thought that surgery might also be an option, but we couldn't agree on the limitations, the neurological limitations due to the Parkinson disease. Could you make just one comment about that, please?
Yes, absolutely. So this patient, of course, was discussed in the R team like almost all our patients. And she's really impaired mobility, moving around in a wheelchair, although she's super young patient, 65. And if you look only to the echo, and with 65-year-old, I mean, I couldn't agree more that surgery will be my way to go as well. But with these physical limitations, with a need for neuro-brain surgery in a few months ahead, surgical team decided it was a little bit too much for this patient for recovery, and therefore we aimed for less invasive procedure, super safe. Probably we will try to get the best result possible. Maybe in this scenario, it's not comparable 100% to surgery, but I think we can have a good job, early discharge, the patient, fast recovery, go to the surgery, and try to improve the quality of life, which is already now quite impaired.
Thank you for clarification. Okay, then take it along.
Yeah. So good evening. So in the echo that I have performed now, before to start the procedure, we could see that there is a very enlarged mitral annulus with prolapse of all the areas of both leaflets, but mainly in both the central and the lateral area of the anterior and posterior leaflet. We have several jets, but the largest jet comes from this area, from central to lateral. And it's also possible to see that we have a huge prolapse in the transgastric views. If we go to the 3D, we could see that the prolapse is affecting all the scallops, especially A1 and A2, also the P1 and P2. In color, we are seeing different jets, but the largest jets and the jet that we are going to treat mainly is the central to lateral jet. And then we have performed the transeptal puncture, really posterior, to try to achieve the height enough. We have, at the end, 4 centimeters over the mitral valve. We already made all the maneuvers with the catheters, and we are really now placed perpendicular to the valve. So we move to live, maybe, and we continue with the case.
Yeah. So first thing we're going to do is to introduce G5, which is the latest, as we mentioned before, iteration from Mitral Clip. And they have done a little bit of changes, mainly improving the ease of use of the device. So they have changed the guide catheter that we have here, no more black screw. We just have a direct attachment to this new stabilizer, and now they have an auto brake that you can move anterior, posterior, and it will hold the position much more easier for the operator. Then the device itself similar. Then we have this attachment to the landing zone of the stabilizer, which means when you arrive to this position, then you are at the tip of the guide catheter, so show a good mark. And then a lot of changes in the DC handle. We get rid of the black screw, so you just have to move this knob, blue knob, to secure the clip, and you can rotate it. You can rotate even 180 degrees, and it's not bothering you, the black screw. And we have improved a lot the locking mechanism and the ease of deployment that you will see in a while. So for this case, we have selected XT wide clip. As Michael explained in the CT, there's super large annulus, super large valve. And our idea is to, our strategy is to try to implant one, probably two devices, long and wide, from center to lateral part. And we have already done the steering. The transeptal puncture was not super straightforward, but because of the height, you see the shape of the atrium is not really rounded. It's like kind of tubular. And the good thing is that we did a super posterior puncture, which required for us some advanced steering maneuvers. We have to give here some negative to go a little bit anterior. And when we compensate to posterior with the guide, we gain also some height, which locate us in the perfect height and position over the prolapse. So the clip is already open. We have aligned the clip, the clock in, and also we have set the floor, as you see, to avoid the parallax. And if we are okay, and the trajectory is okay, that we're going to do a kind of touch, I think it's quite all right. So we are going to go there, and we are going to try to implant the first clip.
Rodrigo, there is a question from the audience asking about the left atrial pressure.
Yes,
please. Did you measure the left atrial pressure?
Yeah, we measured it. It was very low. Patient was quite optimized, and it was around 5, 6. So we decided not to have the continuous monitoring because with so low pressure, probably we don't get so much information on that.
But we do know with Barlow's...
So at this moment, we're gonna...
Sorry, go ahead.
Yeah.
I was just going to say, we do know with Barlow's that it is quite a dynamic lesion too, right? And patient is fully anesthetized right now, and therefore it's not surprising the left atrial pressure is not that high.
Yeah. We also found a little bit of difference in the amount of MR we have now compared to the baseline. But from the baseline, we knew that central and centrolateral parts were the more with the more MR, and we're going to treat based on that, not in the current MR now because it's a little bit decreased. So we are going to advance there very slowly, just below the leaflets, very slowly, checking in fluoro that we are not turning the device. And once we are below the leaflets, we're just going to open it now.
Roy?
We don't want to go very deep.
Roy, do you always cross these kind of
grasping
lesions with the device being closed?
Yeah, open. But we do the same for almost all the... Okay. So we're going to pull. I think we're pulling high. We're in the right spot. Open a little bit more. Okay. Okay, I'm just trying to get even leaflets there, and the device is not turning. Okay. I think we just can drop grippers there.
Hay que utilizar anterior.
Okay, start closing very slowly. You see the movement of the grippers. It means we have quite a lot of tissue there. It was slightly higher here, and we are advancing to release some tension. Okay. Yeah, go. And we are fully closed now. Okay. Good. So I think it's moment to check result.
Wow.
If Manu can...
Yeah. According with the...
Don't clap too fast. Don't clap too fast.
So according with the grasping time, I think that the anterior leaflet should be optimized.
The anterior leaflet should be
anterior,
optimized.
yeah.
Okay.
The posterior, we have all the entire leaflet captured, but the anterior is at the mid part of the paddle.
Okay, that's another feature of the feature of the MitraClip G5. You have independent grasping, and we can optimize leaflets. So we're gonna open. Okay, a little bit more, a little bit more. Always checking that we don't change the orientation in the, okay. A little bit more, okay, I'm going up, okay. So just lift the anterior one. Okay, and I'm going anterior now. Okay, a little bit more. I think we are there. Drop.
Down.
Yeah, and start closing. Lock, and we are closing. And as we are closing and we start to build tension, I'm gonna go slightly posterior, not to stretch the leaflet too much, and advance. If you see in fluoro, we have exactly same orientation, we have to pay attention on that. So we are fully closed now. Another of the changes you see, you don't have this annoying noise. But it's completely closed now.
Some of us miss that.
So we have residual MR in the lateral part. That is the thing that we expected.
Okay, so let's measure gradient, 3D, pulmonary vein flow, and decide if we drop this clip, we release this clip, and then we think it is implanting another one.
Nicole, obviously, tremendous result here. But in general, what would you accept as an outcome in these more complex scenarios, Barlow's disease?
Well, the best result is the best result I can achieve, basically. But we are talking about 65-year-old woman. We went for a TEER because we had no choice. But I mean, here we want to have the best we can get, and especially with such a large prolapse, I would very easily switch to 2 clips procedure instead of 1 if I have any residual MR, also to guarantee a long-term result.
I think it was a beautiful example of how little maneuver and motion was performed once the device was within the pathology, was underneath, was within the LV. All the thinking, the strategy was done still being in the left atrium, and then going across and trying to steer and interact with the valve as little as possible, which Roy and his team have done really perfectly.
So, guys, we're going to deploy this clip, and something that we can review here is the deploy mechanism, which has improved. We did the final arm angle. We completely closed the device, and I don't know if we can see here a little bit better. We can this new way of delivering. Dr. Bat is going to do it. So we just move the wide pinch, remove the latch, and just pull all the way. We don't have to do the locker line as before. So this is a huge advantage.
So while you're doing that, let us know a little bit about your decision making in a second. I mean, obviously, we look at the degree of MR, but here you probably will be fine. But then in Barlow's disease is also a matter of the dynamic nature of the disease and the longevity of your outcome. What do you think? What do you do if you don't see any residual MR at all?
Then we will analyze a little bit the valve and the prolapses. And if we still believe there's prolapse lateral, that was the main pathology at the beginning, I think we will go for a second clip. I think the steering is quite easy, the position, and probably that was our first strategy and our way to go.
Yeah, and we know that from the surgical literature is that if there's residual prolapse, those are the patients that tend to come back because there is that residual stress on the subvalvular apparatus, which will continue to lead to lengthening of the chordae, lengthening of the leaflets, and the prolapse will worsen over time. So I would completely support that notion that we want to correct all prolapse, especially in a younger patient with
And maybe
Barlow's.
one thing we see now on fluoro is how much the clip is bouncing. So even if the result is good, you see that it's not very stable. The valve is not stable yet. So I'm pretty sure we're going to see residual prolapses throughout.
And maybe I don't know what Michael thinks,
was
but from the surgery, we also learned that in this patient, the annuloplasty effect is also quite important. So if you could actually have a little bit more
Yeah, so the annuloplasty is a really critical point, especially there was a series of over 2,000 patients just published a couple months ago in EHJ and European Heart Journal from Karolinska, where they showed that mitoannular disjunction, which was present in 17% of the patients, disappears in 100% of the patients with that annuloplasty. Oh, wow. So that normalization of the subvalvular forces is important for durability and especially important for those patients that have arrhythmogenic mitral valve prolapse, which she does not have.
But we've also learned and have seen that a TEER procedure provides some degree of indirect annuloplasty effect.
Yeah, and to that point, you've seen the correction of the prolapse there where the clip is, but you're still seeing adjacent prolapse, especially of the posterior leaflet. For surgery, oftentimes we correct the posterior leaflet, and then we see that the anterior leaflet, which just didn't have anything to co-op against before, suddenly doesn't need to be corrected. And not patients that have really bad anterior leaflet prolapse, but oftentimes just correcting the posterior leaflet is enough to take care of the anterior leaflet as well.
So if you can just look here, this is what I mentioned before. This is the landing zone. When we put the clip in this part of the stabilizer and then go fluoro, this at the tip. That's another improvement of this G5. We're going to go out, Manu. So we're just going to go out with the clip to the straddling position. We go directly to the vein. Okay. And then we start going down to the valve. More.
And Roy, you plan to place this one medially or laterally?
Laterally. From the beginning, it was the most prolapsing part, centrolateral. So of course, the valve is still prolapsing. We know that. And I think all agree we are not planning like a result for 20 years, like surgery. But we just want to have the best for this patient that has a very complicated life with this neurological disorder, get the brain surgery done, and see how it goes. So in my view, the balance is a trade-off. The balance is quite all right in favor of the edge-to-edge repair, a minimally invasive edge-to-edge repair with very, very few complications. But let's try to get at least best result in the worst anatomy, in the worst part that the patient has, which is central-lateral, even though we don't see much MR now.
Roy, there's also a question about the blood pressure. Did you see an increase in blood pressure as you increase the forward flow and decrease the reverse flow?
Very, very slight increase from 115 to 125. But, it's something at the end. So here the second clip is a little bit guided also by fluoro. Trajectory, I think it's quite okay. And we are going to open now and again check the grippers. Okay, we are opening it on top of the device, on top of the leaflet, sorry. We're going to check both anterior and posterior grippers. So, how is that?
Anterior, the dot, anterior.
Dot is anterior and the other is posterior. We are quite okay. But as you also observe, we have some respiratory movement. So we're going to ask our anesthesiologist to have a breath hold and try to work in that position. Also, Manu, can you check the 3D, please?
Roy, is that something you do very often, to do maneuvers during a breath hold?
Yes, if we feel that we have a lot of movement. And if we're going to go with the second clip in a precise location, we usually the second clip we go with breath hold.
Federico, do you do the same?
Yeah, I think sometimes it really helps stabilizing the whole thing. Obviously, you cannot hold it for too long, so you need to be quick. But Roy is super skilled, so.
So in the most recent version of
keep that for a few minutes, and then you tell me again.
In the most recent version of the guidelines, we had two patient representatives, one from ESC and one from EACTS, and they were adamant that we said something about volume outcome measures because they felt that was very important for patients. Yeah. And if you look, we have a table of those transcatheter procedures and those surgical procedures that we felt should be done in high volume centers, one of them being bileaflet prolapse. So, Philip, would you agree that this is a more complex procedure that should really be done in expert hands?
We go, right?
I totally agree, and I think it is important to realize that what we see now, the expertise, the skill set, the speed, the control, the outcome, that's the result of having a vast experience with different pathologies and having treated many of these patients before. This is obviously not something you will end up at the first time. Having said that, at the same time, I mean, our understanding about imaging, the echocardiographer, the devices, the knowledge about the disease has advanced so much that I'm very often surprised that even beginners, how fast they can achieve very good results. So it's not an easy clear-cut answer to that for me.
I have also a question for Mike. I mean, we've seen the results of the poll, and people were somehow favoring maybe surgery. You said the surgery is definitely a good option for this patient. After knowing that she's wheelchair bound, and we know how low mobility impacts surgical outcome, would you change your mind, or?
Yeah, wheelchair bound. I don't like operating on wheelchair bound patients. I also don't like operating on 80-year-olds. I'm not one of these surgeons that thumps their chest and says everybody's a surgical candidate. I think there's a very appropriate decision made in this patient. If we were to operate on her and the repair wasn't possible, which is, for Barlow's it is higher than just isolated P2 prolapse, then the fallback would obviously be a biological valve, because you don't want to put a mechanical valve in somebody who has a neurosurgical appointment in the next few weeks.
No. Okay, we're just working here.
But the problem is that it's high risk, right? That's what the recommendation says. In high risk patients, TEER is a good therapy as a 2A now instead of 2B in the previous version. So high risk then is based on so many factors, and the best scoring system we have is the STS risk model. But that doesn't take into consideration these rare sort of comorbidities that may not increase the risk of the surgery itself, but certainly the recovery after the surgery.
And also another thing that you need to factor in is the transcatheter repairability of the anatomy. This is a challenging anatomy, so that also needs to be accounted for.
Wait.
Maybe a few words about predictability. I mean, Nicole, in these anatomies, how good are we in predicting the outcome with TEER? And then after that, I will ask you, how good are you as surgeons in predicting whether repair is possible or not?
I guess we are becoming very good in predicting the result. We are not that skilled compared to surgeons to predict the long-term result. I mean, the outcome, we can assess the valve, see if we have any cleft, see the height of prolapse we have. I mean, we can predict the immediate result, and especially during the procedure, we can adjust to get the good result. But the question is a long-term feasibility, the durability when you have a Barlow disease and bileaflet prolapse, and this is where surgery has an advantage.
Yeah, but even for surgery, of course, then there's multiple studies that have shown that if it's isolated anterior prolapse, or if it's bileaflet prolapse, the results are not as good as isolated posterior prolapse. We also have a paper coming out here soon, which is a multi-center study, but it's also prospective data from randomized trials, 3 different randomized trials from the US, which confirm that bileaflet repairs are more technically challenging, and the long-term results are not as good as isolated prolapse repair. Having said that, isolated prolapse repair, the results are very hard to beat. But we will find out with repair MR in a few years for intermediate risk patients, and we will find out for primary MR for all elderly patients, regardless of risk, in probably about another 4 or 5 years. Repair MR is finished randomizing or acquiring patients, correct?
How long of a follow-up do you expect in this primary mitral regurgitation patients to see an impact on outcome and to see some meaningful differences between transcatheter and surgical repair?
So for the primary MR study, we have a longer follow-up. We have 3 years before we're going to analyze the data. Repair MR, I think, is a bit shorter, but please correct me if I'm wrong.
Correct.
Yeah. And we do know that if you don't have any residual other prolapse, the chance of the patients coming back is low.
Okay, let's go back to Vigo. seemed as you tried to be really as close as possible with the second device to the first device and went back into the left atrium and tried to have a better approach. Is that correct?
Yeah, absolutely. So we asked for a breath hold. We dive in. We try to be as much as close as possible to the first one. And, but we didn't get a very good catch in the posterior leaflet. And we redid it, and now I think we are in a better position, and we are going to check. Yep. Looks like both clips in the floor are parallel, and we are fully closed, and we'll see now.
And Roy, the clocking of the device, you are sure to have the right clocking before you cross the valve, and then after that you 100% rely on fluoroscopy, but you don't do another 3D before you close the device. Is that your go-to approach?
But I mean, we have some bad imaging in the lateral part, so we just rely on the fluoroscopy, and then let's see the result and the 3D if we have enough posterior leaflet. Otherwise, we will redo again.
There's also a question from the audience about if the patient did undergo surgery, if we would do something to the tricuspid valve. So that's another thing in the most recent version of the guidelines that we stated, I think, a little more clearly, especially with the results from the CTSN randomized trial showing that if there's moderate TR, you should intervene. And if there's mild TR with annular dilatation, you should probably also intervene, although it's a 2B, whereas moderate TR is a 2A, in order to prevent future RV remodeling and future significant TR. So can I ask you then, Roy, what was the tricuspid valve annulus size here? On the echo, it looked like there was even some mild prolapse of all of the tricuspid leaflets, which you often see in Barlow's patients. Did you have a chance to measure the annulus?
We did not, although we have the CT. But I mean, as you mentioned, sometimes Barlow disease, or frequently Barlow disease, affects both mitral and tricuspid annulus. So it's a really enlarged annulus as well. So of course, if you go for surgery, then it's clear that probably you have to address that, even though the recommendations from the guidelines has been downgraded in case of mild TR, which is the case. But in this type of pathology, probably it's worthwhile to put a tricuspid ring as well if you do surgery.
Explain a little bit what you're looking for now, please.
Yeah, we are trying to get a good image to make sure posterior leaflet is well attached to the device. That, I mean, what's the doubt? We have some, when we enter, probably we displace a little bit some chordae. And we were not sure with the imaging if we have enough posterior leaflet. And that's what we're trying to do now from different views, even transgastric view, which we are very used for the tricuspid, but also now for mitral also give us some understanding on what's going on.
The problem is now the lateral clip that we have placed, the trajectory of the probe, the transesophageal probe, is the same of the catheter, so we have a lot of shadowing coming from the upper esophageal view. So we go deeper, and we are trying to see also in the transgastric that the grasping that we have, the tension on the leaflets. Here, for example, that we have a very nice view, but we have the second angulation. You could see there, it depends on the angulation that we have. But probably here from a 3D with MPR, we could explore.
Yeah, so the good thing of this procedure is, I mean, we are not in a rush. We take our time. We just review all the images, make sure 100% that we have all the leaflets we wanted in. And in case we are not happy, we just open, recheck, redo. A lot of, patients super stable.
That's the right direction here, this one.
And blood pressure has increased even further. It's now 135.
Nina, do you think that the valve looks more stable now and that there's less residual prolapse?
Well, it's indeed difficult to say. We are commenting once you have this relatively worse image quality. It's very difficult, but the MPRs was what I would have done as well, because then you can really check if that part of the posterior swelling seems partially in, but when you see the 3D, not completely. You can see there. So I would maybe try to see if you can get better the posterior.
Yeah, so we have some doubts there. We are reopening again. Now we have the MPR, and we are trying to figure out if we're okay. I'm going to open a little bit more even. Okay, and so I think the problem is we are too low now. I'm going to come up a little bit. Can we raise the posterior? Let's see if the posterior comes. Yeah, you did it? Okay, yes. So trying to go slightly posterior now. What do you think, Manu, there?
Yeah, I think that the posterior is beating over the puddle.
So the anterior gripper is still down, and the posterior you raised to do a single leaflet.
Yeah. That's what we're trying. Going up and down to see if he enters better. I think it's there, right?
Yeah, it's there, it's there.
Yeah, we're going to drop the gripper now.
Yeah, for sure.
Okay, we have some movement there, and we'll start closing again. We lock the clip. I will keep this posterior tension with the guide, and then we are closing. I think we are building some tension there. Okay.
Yeah.
Okay. What do you think, Manuel? I'm still not sure 100%. If you see the 3D, looks like it's opening the posterior part.
Yeah, here in this area. You have to take a second look, maybe.
Is this the position where there might be a tiny bit of an indentation? Because obviously the posterior leaflet is long enough and shouldn't be too difficult to
probably we got caught in some corner there.
You see here in the 3D that we are not catching properly the posterior, so we have to do again, open again and try to do.
Okay, so let's open again. Let's try to have better. Okay. We go opening. Yeah. Starting. Wait.
Federico, indentations. Right. Is that something you avoid, or do you think that that's as long as you go deep in enough, it's something which is still suitable for device placement?
Okay. Well, it's a wide chapter, and there are lots of variations. So as a general, discussion, we try to avoid going directly into the indentation, try to stay next to it, but it really depends on the morphology, how deep it is, where it does extend, where the main lesion is, if it does contribute to the mechanism of the mitral regurgitation or not. So there are really lots of factors that need to be accounted.
Maybe can I ask Roy just a question? Do you think now that you are back in the... Oh, this is what I was going to ask you, whether we can pull back a little bit the system.
That's what we did. I mean, I think we were attached to something, and we decided to go slightly out if we could. We were attached to some part. So we're going to try to redo this part again. So, Manu, if you can check the orientation, please. Yeah. Let's make sure we're okay. The other clip is super stable. So, yeah, I think the orientation is not that bad. We're just going to go slightly lateral. Okay. You okay, Manu, with this orientation?
Roy? What we're going to do is we will hand over to Nico. He will highlight some of the procedural aspects so far, and then you have the time and continue. We will come back to you in a second. Okay?
That's great. Yeah, okay. Absolutely. Manu, voy a cruzar ahí.
Please.
All right. Yeah, thanks. Okay, Philip. So maybe what we'll do is they started off with transeptal puncture. It was a primary Barlow's disease, so height is very important. We heard the operator say that. So although we didn't see the transeptal puncture in action, there was some... Yeah, maybe you want to put the smart screen in the center.
We can switch the screens, please.
Ahí mejor, ¿no? Ok, baja. Vale. Cierra. Espacio, espacio.
Okay, so we'll just, if you just look on the top left of the screen.
Can we put the smart screen in the center? Is that possible?
Lo tienes bien, ¿no? La roja está bien.
Okay, we'll carry on.
Yeah.
Okay, so if you look on the top left of the screen, we're trying to get some idea of the transeptal puncture characteristics. In the upper left corner, you have a 3-chamber view. In this case, you have the atrial septum, which is en face. You can see that it's not an it's not a aortic hugger. Okay, so that was one thing that I was paying attention to. And you can also start to see the trajectory that they have with their catheter. The other thing is you see the nubbin of the catheter here, and it looks as if it's in a nice position to be coaxial with the commissure to commissure distance. So those are some of the things we were looking for. It was clear that the operators were using quite a lot of fluoroscopy. And you can see here the TE probe is perfectly in plane. And the reason why it's perfectly in plane is because the mitral valve is perfectly in plane. And what the operators did, but we didn't see, was they oriented the clip on echo and then moved their C-arm to get their clip in profile. And so what they were using was an REO13 cranial 3, which is somewhat like a bicommissural view, but on fluoroscopy. Okay, so that was the view they were working on all the time, and they got that clip in plane. The other thing is, again, trajectory here is super, super important, and so that's why I put these 2 stars here. You can see on the 3-chamber view and 2-chamber view that we have a really nice trajectory that's perpendicular across the mitral valve. The operators then continue to look at the clip orientation. Here's the clip that's closed, and the clip that then opened on the top right here in the ventricle. And you can see that it's still in profile. And finally, when they grasped the leaflets, it remained in profile. So they were constantly checking on fluoro and echo regarding clip orientation. And then they went and used, when they were going for the second clip, they told themselves, okay, we have the first clip in profile, let's quickly orient that second clip in profile as well. They went to echo 3D, and you can see that it was almost in perfect position already. Okay, so you can see how fluoroscopy and TEE can communicate to each other. And finally, they were trying to position the distance between the 2 clips. Sometimes that can be difficult to appreciate on echo. The fluoroscopy can help as well. And finally, just wanted to make a final point about multiplanar reconstruction. They were using multiplanar reconstruction. They had a cut line here and here. Okay, this behaves similar to CT, and you finally get the short axis view over here. And they were looking whether or not there was a proper attachment to the posterior leaflet, which it was a little bit devoid there. So they went ahead and tried to reorient themselves. So maybe we'll go back to the live case.
Thank you very much, Nico. Nobody can explain that so clear and precise than you. But let's go back to Vigo, please. Roy, what have you done?
All right, so we just, as Nicole mentioned, I mean, this is another big thing in the edge-to-edge repair. I mean, you are not in the right spot. You just go out, rethink, reorient, and go again. So that's what we did. We have a good grasp. I'm going to show you a cine. Clips are now much more stable, moving around. It looks like the prolapse a little bit much controlled. And this is our final 3D that you can see below. And maybe it's not like surgery, but not bad result for this case, which was very complex. I don't know if you want to make any comment, but I think we observe how it works. The new G5, much more controlled, predictable, operator-friendly. I think it's a big step forward in the mitral clip as well.
You weren't happy with us clapping too early, but you have to accept that we will clap now once again. I congratulate you to a fantastic outcome. it was really a beautiful demonstration of a clear understanding of the pathology, of imaging, of a strategy, a plan, execution of the plan, but then maybe in between encountering some problems, changing the plan, but always very controlled, knowing exactly what needs to be done, and then the outcome is as perfect as you have shown. So thank you very much for that. Again, one can congratulations. And with that, we come to the end of this session, state-of-the-art therapy for mitral regurgitation, state-of-the-art because considering always the evidence and the guidelines, state-of-the-art because using the latest iterations, the MitraClip G5, and most importantly, state-of-the-art because it was shared decision-making within the heart team involving all the disciplines, surgery, cardiology, EP, heart failure. This is the way forward. I would like to thank you for your interest. I would like to thank the fantastic panel, you for guiding through that session with me, and I would like to invite you now to leave the room and enjoy the reception with drinks outside and have a great rest of your day. Thank you very much.